Thank you very much, Mr. Dakila. So now it's the second part of the conference. We are going to have a plenary with all speakers. So I'm going to ask the speakers to come here in front and sit. And Michel Bernier will be the one who will be the moderator for this part. So Michel Bernier is the founder and managing partner of Pivot, a boutique strategy consulting firm specializing in the financial services, insurance, and health and life science sectors. Drawing on more than 25 years of consulting experience in Canada, the US, and Europe, Michel has advised CEOs and senior leaders on topics of strategy and business transformation. He holds a PhD in industrial organization psychology from the University of Montreal and is a certified director of the Institute of Corporate Directors. So thank you, Michel, for being here today. Thank
you. Thank you very much for your thoughts. I thought it was very, very enlightening. I'd like to take this occasion, since we have the wisdom in this room, to really deep dive a certain number of questions that are probably top of mind for a lot of people in this room. As you are aware, some of you very well, others perhaps less, Quebec has started a transformation journey. And I'm saying started because you're talking about Dr. Peake, you were talking about a 40-year journey. Perhaps this one's not going to be that long, but you've all characterized it as a journey. And I would say that we're probably at a start of this journey. So I'd like to bring you back to some of the questions that are probably very top of mind at this stage in the process. I guess the first one I'd like to touch on, and by the way, I'd like, as we go through this, if you have any points or comments that you'd like to make, please, you're more than welcome to intervene. I think we've heard from Dr. Denis that structurally driven change doesn't work. That's not, well, it's probably a necessary condition, but not a sufficient condition. But then again, when we've heard about all of you, Dr. Baker, you started by talking about some of the big amalgamations. Dr. Peake, you talked about how important having one network was. Same for you. Richard, you talked about the importance of having clear organizational guidelines. So perhaps the question here is, so it's clearly a passage nécessaire. So, how much we've all agreed that consolidation is not integration. But how much we're seeing the US consolidate very rapidly for all kinds of reasons. We're seeing systems come together. How much consolidation is necessary, and how much is enough? Is bigger better, and how big do we need to be effective? I guess these are the questions from that perspective. Whoever would like to start. I know it's a big question, so whoever would like to start.
I'll go ahead and just make a couple of comments on that. I tried to suggest to you that even when you have a big system, you've got to get it down to a local enough level. Yeah. And we, in ours, both the VA and the DoD system, even though we have large regions, there's smaller segments within it that really are part of an integrated delivery system, if you will. And I would, my own. Can you hear me? Sorry. The notion that you can have a large system with common standards, but that, as you saw in my presentation, we broke it down into regions, each with subordinate organizations responsible for the holistic care within that region. And even within the regions, as I pointed out with Palo Alto, you have a subsystem within a larger system. So you want enough of a reach where you have appropriate span of control, and then you have the accountability all the way up and down. As to the components of it, I think, Richard, I think you addressed it too, that I think we're seeing more in the United States of vertical integration. You say why, and I think some of the ACO push has driven it in that way. But I think there's a increasing understanding that the continuum of care means dealing with the post-acute and the pre-acute. And with the hospital, the kind of the focus factory in the middle, if you will.
Yep.
So there's an interesting history in this country. 30 years ago, we worked almost across the country to create regions to help decentralize care to local geographically defined areas and to manage the care on that basis. In creating those regions, we often left out vital parts of the healthcare system, including physicians and some other elements, and depending on which province you looked at. And I think there was a frustration in some levels about the inability of those regions to actually take advantage of the opportunities they had to integrate care at a local level. So now we see, 30 years later, we see a sort of a trend the other way, and we've had Alberta and recently Saskatchewan and Nova Scotia before that make some changes now to deregionalize their systems and to de-emphasize local control of that. But I think there's a balancing act that needs to be taken into account here, and that's that we need to create some efforts to standardize and to communicate across the system for people working in very different environments. But as I tried to suggest in my talk, I think the core driver of success in healthcare systems is the ability of integrated clinical teams, sometimes across environments, to work effectively together to use their skills and knowledge to care for particular types of patients. How we do that will require a variety of tools, and Mr. Takina really did a nice job of describing the way in which those tools come together, informatics tools, telemedicine tools, but it really relies on creating that local environment, that local ability to move people into a different way of working and not see their own corner of that as being the only thing they're really interested in. So in a way, the challenge for professionals now is to not only think about what their clinical skills are, but to think about how they work effectively with their colleagues who may be at a distance in order to coordinate care for the patient who's either with them or they're somehow responsible for. And I think that's the challenge. So structures either enable that or they don't enable that. And I think that's the value of the structure is the extent to which it can create this environment where the president and CEO of a very large system can feel assured that every day there are these teams working together to care effectively across geography, across organizational space, and manage these patients.
I still don't have a great answer. It's a really tough question because I think that every situation is different. Our regulatory, political, federal environment is different. I worry about too big, and I worry that that you can very much get to a tipping point where you completely are not. You have to respect the local level of involvement and the unique situation of submarkets. And if it becomes so large that you get divorced from that, I think then you're not going to be successful ultimately. So I just think it is going to be tailored to each situation and what the community needs. I don't think you're going to get any of this done if you can't get the community, the public, and the providers to embrace an idea of how care can be better and what clinical standardization and program leadership can provide. Once you lose that, then you're going to have to overcorrect and go backwards, and maybe that becomes the way you define how large a system can be and ultimately how it's structured.
Well, I guess just to build on the previous comment, structure is our starting point or a kind of arrival point. And then in between, you have a space. And your question, how much consolidation do we need? I would say it depends what you can do with, which lever you can activate to create these various level of management, clinical accountability, performance management, up to the point of care. And I think many of the comments refer to it's not consolidation by itself. It's not bad to have it, but which opportunity you will find in. And I guess the other issue is what you consolidate. We already have, as an example in Quebec, a broad range of mission under the same governance structure. So how much you want to go further on this and why to create which value?
Anybody would like to Anybody would like to comment on that? Not really. Move to the next point then. Oh, yes. Sorry. Yes. I don't have that.
I would just like to say, Mr. Bernier, that the journey started a long time ago. This is the start of the journey. When we started in Quebec developing PLCs,
Sure.
very satisfying
Sure.
and seemed to answer the breadth of need until you need an acute care hospital.
Yeah.
So as we move forward, I hope that those experiences are not forgotten and that we can look at the best of them.
Yep.
Because they weren't all perfect, but some of them really worked really well. And that we can build and bring those experiences into whatever is going to happen.
That's a good point. Perhaps moving to another topic, I was listening to the wisdom around the table. I felt I was around a Chinese buffet. I had all the ingredients here, but I really didn't know where to start. And again, those eight building blocks are great. We've talked about leadership, we've talked about vision, we've talked about patient engagement, we talked about. So given the humongous, and everybody said it's complex, it's complex, it's complex. You've mentioned you've mentioned the word transformation journey. You mentioned that, Dr. Baker. So as we look at this transformation journey, again, based on your experience, some of you are farther along in that journey. What are some of the key steps? What are some of the key inflection points? What is it that we cannot miss? What are the must wins as we go along? Again, providing some guidance in terms of that journey.
At the risk of, I'll start oversimplifying, you have to find a way to create an agreement around principles and vision. I mean, it sounds so trite and simplistic, but unless providers, the health systems, and patients can be engaged to articulate what do they want from, what is success? What do they want from a healthcare system? What do they aspire to in terms of access, in terms of cost, in terms of clinical sophistication? If you can create that framework and alignment, the going is going to get rough. You're going to hit all kinds of obstacles. If you can reach back to those principles, then they will sustain you through anything that you subsequently build. And beyond that, every situation is unique. But I think if you don't have that kind of alignment up front, what it is we're going to build, how it's going to take care of folks, what are the dimensions of success, then it will ultimately disintegrate without that consensus.
Just to add to that, because I agree with that, I think the critical issue now is to move from strategy, and there's a pretty wide agreement on what the right strategy is, and I think we heard some very similar themes here, into execution. And execution requires a couple of elements here, but one of them is the role of leaders in ensuring that people understand what that strategy is, but equally important, their ability to get people to engage with the strategy and to provide meaningful feedback and then contributions to that strategy as it moves forward, because you cannot work in a large system without knowing that at the end of the day, it's the local engagement that makes that strategy work, right? It's not the description. In Ontario, we have a very clear strategy, and I think it's a sound strategy, and it resonates against the issues we heard here today. We struggle with execution. We struggle with putting into practice, changing what people do on a daily basis. And we don't have all the levers and the incentive opportunities that they have in some US environments. And so that limits what we can do, but we've relied very heavily on setting very strong performance expectations and holding people accountable. And I would say we have not done the necessary concomitant to that, which is give people the tools, the skill, and the support to make a difference. And I liked your description of the clinical redesign work you had, and you said not only do you have those teams there working, you have them supported by people who have the skills, the knowledge, and the data to actually help them make a difference. And I think that's, when I look around to what's happening in Ontario, you have lots of bright, capable people, but they already have full-time jobs. And so the hours that they grab from that clinical responsibility to actually change the design of care, it's very difficult if we can't take full advantage of that.
I guess I'd take it up a level and say that you talk about a journey, which I agree with. And the kind of what Yogi Berra said about journeys is that if you don't know where you're going, any road will get you there, right? So the issue is fundamentally, where is it you want to go? What's the gap between now and what you envision the future? And then how do you share that vision? Because it means that each component of the system will have to adjust and change if that vision, depending on what that vision is and what are the metrics that you're going to say are important as you move forward. So I think that's an important piece of it. And it's why on that balanced scorecard piece, that it was there were some really broad objectives there that appealed to every one of the stakeholders and were important to each of the stakeholders.
Well, just maybe to reinforce some of the comment, I think that there is this question of targeting a certain limited set of high impact outcome in a system, what we want to improve. And we saw in Canada now debate around home care, mental health, and so on, and creating the engagement around this outcome. And I think, and not just in Quebec, in most of the province, we have major engagement challenges. Like when we talk about reinforcing the connection or the integration between physician and the system, we hear story from our colleague in the South that have different type of arrangement, and I think that changed the game to achieving the kind of success they achieve or the journey they are in. That's one of it, and the question of looking forward, like if we take the case, and I think we saw this with the military and the case of the immense potential of ambulatory care in 10 years from now, in 15 years, and which kind of model we can develop to use it as an opportunity to engage the medical profession in improving the system. So I think we have key area like this that would be very strategic for the becoming of the system.
I think you've mentioned engagement a lot. Any specific initiatives that you've seen have worked very well in your systems in terms of stimulating that engagement with providers?
Well, I for us, clinical redesign, we have, and this is an institutional response, it's not a health system response. There are two things that we have done that fully recognize it. Unless the physicians and the nurses and nursing leadership are connected and on board, you can have all the great strategy in the world, you can be dead in the water. And there are two things that have done that. One is what I mentioned earlier and won't belabor clinical redesign. If physicians and others feel they can engage in a process that eliminates variance and produces better outcomes, they're engaged and excited when they see that those changes are sustained. Second thing we've done is try, and not just us, others have done this. We steal shamelessly. Have created this concept of a dyad, that every operational unit or clinical enterprise has a physician and a nursing leader who are joined at the hip, who operate as a functional team and are seen as the leadership team. They're held accountable. It's more about execution, but it reinforces that this is a team sport, and that we expect our leaders to function in teams and to be connected that way.
So again, I agree. I mean, I think we sometimes think that we can move systems by changing policy, changing reimbursement, changing regulations, changing performance objectives. But it really has to be an engagement, which means a motivation, and people who feel like they're acting on the rationales that brought them into healthcare to begin with, which is to provide better patient care. And that's what makes the difference. And if you give people the opportunity to become engaged in that and support them in doing that, it's fascinating how they will turn around. So I have led a master's program in quality improvement patient safety at the University of Toronto for the last 5 years. And we take 30 students a year. Half of them are young physicians just starting out in their career. And we hear a lot of stories about, the continuing struggle of people entering medical practice and, the sometimes challenging environments they have from their attendings in terms of making life a little difficult for them. So these are people who've survived a lot of that training, but they are so engaged in what they're doing because they now have the skills to say, I'm not the victim, I'm the author of my future. And I can find people to work with who have that same view, and that creates enormous energy for the system. And what I see in a lot of places is frustration, burnout, overwork. And what we have to do is reverse that and give people the opportunities and the support to allow them to work on for the best reasons, for the best purposes.
Any other? Yes, Eric?
Just trying to figure out how to make it work. And there's got to be some source of energy to develop that vision, those standards, the view of what the future looks like. And I'd be interested in your views of where it comes from. I mean, one of the obvious questions I would have is the role of the medical school and the university. Leading on that. Where does that drive come from?
Well, I would say that the medical school and the university would have a significant role in it, but it is one of the entities that is involved. And I think the issue is getting all the players at the table. You start looking at and then checking out their discrete areas of responsibility and what they add to the solution to the problem that you define. When you look at the university and the medical school, as I suggested, in both the VA, the DOD, and then what I heard in a relatively small system, education and training and engagement with research was fundamental to the impact on quality within the system in terms of attracting talent, in terms of keeping people on the front edge of where we're going. So I think it's tremendously important, but the health system doesn't exist to support the university. It should be the other way around, right? And so I think making sure that it is viewed and engaged in its appropriate role is important, but as part of a contribution to the larger goal of the institution.
I couldn't agree more. From my environment, if the university drove it, it wouldn't create the table setting that we need for all of leadership to come together and address these issues. And so would have to create a balance, and you'd have to pay a lot of attention to who is at the table and what role they bring to it. But really strive for balance and engagement across the board. These are leadership issues. Unless we address them, no one's going to do it for us, and we're just kicking the can down the road. So I think a lot of thought has to be given to that, and getting everybody in embracing the issues.
Maybe just to add on this, one of the possible role of university in partnership with the health system is helping working on a strategy in terms of innovation. Because when we talk about engagement, you can have strong engagement locally, the kind of energy that Russ described. But then if it works, you need to generate evidence, scale up, and put at the level of a system and document that systematically. And this creates energy too in the system. Many of the exemplars often we discuss. It can be in Canadian province, it can be in US, in Europe. People will talk about the benefit of systemness when you feel engaged beyond your immediate work context, where you feel that other people struggle with the same and try to implement this kind of model. We refer to co-management. We had some good experience in Quebec and other provinces in co-management. We should probably push this as a way to engage clinician and management in a joint venture.
I think what I'm hearing you say is two things. One, systemness is about engagement and engaging, and it's a leadership game. I guess as administrators, as leaders, one of the responsibilities is to create the facilitating conditions for this, for all of this to work. If you had to name 2 or 3 of these facilitating conditions, what would they? And I know you've talked a lot about this, but I'm trying to get around the Chinese menu here. So the buffet. So if you had to name 3 of those top facilitating conditions to actually create that kind of engagement, based on your experience, again, what would that be?
Well, I'll throw one out to start with, and that is the ability to have a common operating picture and good data that is transparent, and the systems that support that.
Okay.
Consequences of inaction is getting clarity and dialogue around what would be the consequences of inaction, and why that couldn't continue as a facilitating condition.
Okay.
And just to add that, I think we talk a lot about the learning health system, systems that learn how to perform better over time. And part of that is clinical learning about what works for patients, but part of that is also the kind of learning about how we then create systems that work better together. And the science on this is still relatively young and incomplete.
Yes.
And I think what we have to do is start to support efforts to understand how to do this in different ways that provide meaning in local environments. Because what works as a system of care in Montreal may not work in rural Quebec.
Sure.
And it's that sort of constant sort of iteration, experimentation. I said in my talk, I mean, there's such a large investment in trying to understand what that looks like, and not all those experiments are going to be successful, but we may learn from them to think about what the elements are at a local level.
Well, maybe we repeat ourselves, but I guess one factor is clear improvement objective that can cascade down and adapt across the system, and that makes sense for people who deliver services. And the other aspect is balancing accountability with support to people and capabilities development strategy. And there are technical aspect to this information, and there are soft aspect, which is teamwork, team effectiveness, and I think we need to balance both.
Thank you. I don't know if there's any more questions from the floor. Yes.
I'm going to ask a question that I think has already been asked, but I'll just try and ask it a different way.
Go, please.
The presentations, I felt that we got a really good menu and lists of essential components that need to be in a system that's adapting, that is working effectively.
Yeah.
So it's not just size, but size alone won't put, there's 8 or 10 things that each person said. What I found interesting was Mr. Bernier's answer to get how the question was put, but talked about 2 things that really get his attention. One is competition, and another is issues related to funding. I don't understand the U.S. system of funding, so I don't know what exactly that means.
It's shrinking.
Cost
It's going away.
I know what money is. So from the kind of point of view of sort of the inside of an entity, I think we've got a really good visit of the essential components. Now here we don't have competition, so or at least it doesn't look to me like we've got competition. So that's what I'm getting to is what are some of the external
Drivers
that would drive an organization to try to use the internal levers that we talked about. What's coming from outside that makes an organization want to do this in the first place?
Well, I'd ask you, I mean, what do you see the problems with your health system here? I mean, what is it, 51% of the dollars in Montreal go to healthcare and growing? That's a pretty significant challenge. Your tax rate's pretty good compared to ours, I think, actually. Pretty high, I mean. So, if you look across
we understood that.
Yeah. If you're looking across your population, does everybody have access to a primary care provider or get the care that they want? I mean, I hear no. And so I mean, it's what I was saying. What are the problems you're trying to solve here? If everything's working perfectly, I don't know why we're, what the discussion is, but it sounds to me like you've identified some issues that you want to see addressed. And then the question is, well, what's the system changes or the systematization that might help you get to that goal? It's not doing it for just doing its sake, I would submit, but it's what is it that you want to be better, and what is your baseline so that you can actually measure it? And I think those are the kinds of questions that need to be asked, as opposed to, well, how do we change just to change?
Question.
There is a
Wait.
Answer the question, what we want to change, what we want to change. A very good example. I'm a second-year medical resident, just finished 4 days ICU night call. And one thing that is quite shocking is how our system, the example that the Americans gave, especially in terms of communication. So he's talking about an electronic chart where the patients can enter files, see their names, and all of that stuff. We are not even close to this. A pharmacist can communicate with a doctor by a handwritten note that's written in Sanskrit. The hospital communicate by fax in 2017. I have one perfect example earlier this week. He's got an intubated patient that's bleeding his head and was pulsing. We need to transfer to McGill. We cannot get a hold of him for an hour. The only way we got a hold of him was for our Saudi resident to text his Saudi buddy neurosurgery, texted his buddy for a long time. So I think that is something that we clearly improve on and even talk about Systemness with the system.
I think that makes the point we're talking about. I think Rich DeCino talked about, having addressed that problem from a systems perspective, specifically the kind that you're talking about, and the fact that, with the transfer center and And looking at it from a multi-institutional system, you have the opportunity to make those kinds of adjustments, and you can measure it.
I think we had another, yes.
I'm a strategy consultant. So we talked about, we've all talked about things that we should do, the key success factors, principles. Were there any things that you think we shouldn't do? Any lessons that were learned, mistakes that were made that you think should be avoided? Or everything that was done was,
So it's a really good question. I think going back to this issue about accountability and capability, we have really pushed very hard on the accountability button in this country in different ways, but we haven't always given people on the front line the capability to make a difference. So, I mean, you can make ICU residents responsible for the quality of care, but if you don't give them the tools to do that, then it's a very difficult thing. And I think that's a larger lesson. We have to figure out how we use our resources to build capability within the system. And it's not just informatics; it's around the clinical redesign piece. Many people work in systems where they see the ambiguities and perhaps inefficiencies that leap at them. And if we can't link those people into efforts to actually improve the way in which care is given, then we have not given them the hope that they're going to be authors of their own future. So I think it serves the system, it serves the individuals in the system to figure out ways that we can sort of tap into that energy, because that's where the change happens. The change happens in the front line, redesigning care within a context that's supported by leadership with resources to make it happen.
I would echo that, and I would not get frustrated and give up. I think that because it is easy to do that. I can tell you the same stories in our healthcare system. You don't own them just here. I think there is still enormous potential to convert waste and bad outcomes into better outcomes and productive energy. As bizarre as that sounds, everywhere we look in our system, we see waste, and we have to live on that waste and root it out. And I consider waste bad outcomes, unplanned events, complications, and I think as long as we stay focused on that, there will be resources to convert that into something that is productive and value added for patients. So I guess the things I would not do is get discouraged or stop looking at opportunities to improve things.
Thinking of your question, that what to avoid, I guess is what you're saying. And I'll give you my sense is you got to keep listening, and you've got to keep engaging. And I think maybe I'm saying the same thing in a bit different way. But when at some point somebody makes a decision, you got to have some decision maker that says, okay, here's the direction we're going to go. But you got to keep judging that from the eyes of the provider and listening to the feedback and responding to it appropriately. I can tell you in my experience in the DoD, we actually rolled out a system that we thought was pretty good, and the clinicians hated it. And we were really slow in responding to that. But eventually it got fixed and so forth, but it wasn't quick enough. And you really have to be engaged with all levels of the organization and listen for that feedback, and having mechanisms to listen for that feedback, not just listen, but actually respond to it, so that you can do the gradual course corrections. Because in this journey, it's never exactly straight because of all the confounding external factors that in a complex system that nobody really can completely predict.
Yeah. Eric, you had some, no, sorry. Is there another? Well, unless you have any closing comments, I think it's been very useful. Thank you very much to all of you.
That's great.